Hello, I'm Dr. Mark Miller, and I am a gastroenterologist, a clinical gastroenterologist. Gastroparesis has been around for a very long time, and the problem with the disease is that up until now we really haven't been able to talk about cure. We've been able to talk about control, but really not so much about cure. And the reason we couldn't talk about cure so much is because we couldn't predict the subtypes or the different subsections of disease with regard to gastroparesis. Now that we have electrogastrography, what we've been able to determine is what the subtypes are. And by looking at gastroparesis subtypes, and also looking, therefore, in a more detailed manner at the interstitial cells of Cajal and their role in disease, we can now talk about not only control, but actually cure of different subsets of disease. We know that with regard to gastroparesis, the cause is traditionally poorly understood, and as a result, treatment successes are also unpredictable. However, with the advent of electrogastrography, being able to detect the gastric myoelectrical activity, and knowing, based upon biopsy studies and numerous other studies, that it is actually the interstitial cells of Cajal, the quality and the quantity of those cells, that determine gastric myoelectrical activity, we know we can use EGG to directly, looking at the 3 cycle per minute signal, directly correlates with the ICC quantity and quality, and this has been proven in biopsies. So when looking at normal patients with normal 3 cycle per minute activity, that is a guarantee that there are at least the normal number of ICCs, which is a minimum of 5 per high-powered field. We're then able to take the EGG findings and subtype the type of gastroparesis based upon the quality of the ICCs and the other factors we find on the EGG, in particular the 3 cycle per minute GMA, or gastric myoelectrical activity. So only EGG has been shown the ability to detect this 3 cycle GMA and therefore show us, without actually invasively taking pieces of people's bodies, what the ICC quality is. I like to divide these subtypes into 4 or 5 different types. So first we want to look at the normal 3 cycle per minute GMA. These are the non-obstructive type patients. This is often associated with gastroesophageal reflux disease, which predicts resolution with correction of the reflux disease. It also means that with normal 3 cycle per minute activity, our ICCs are intact and function normally. Another subset are what we call the hypernormal 3 cycle per minute GMA patients. Now in these patients, we'll see 3 cycle per minute activity recorded on the graph well in excess of the population-based normal levels. This is usually predictive of what we call functional outlet type obstruction. So there's not a mechanical obstruction, although you can see the same finding in mechanical obstruction, but this particular subset, endoscopically the pylorus looks normal, but yet it's a functional obstruction. And this predicts response to either pyloric balloon dilation or injection of Botox endoscopically into the pylorus, or subsequently surgical therapy to surgically open and keep the pylorus open. Also in these particular cases, since the 3 cycle per minute activity is not normal but above normal, we also know that the ICCs are actually very intact and also of normal quantity. The next subset is going to be tachygastria or bradygastria, and there we have to look to whether there's concomitant normal or abnormal 3 cycle per minute GMA. When we see tachygastria or bradygastria with normal 3 cycle per minute GMA, this means that the ICCs are intact and normal, and based upon studies in the literature, it also predicts that there will be a successful response to the insertion of a stimulator, as an example, to try and straighten out the gastric rhythm. However, in the case of another subtype where you have tachygastria or bradygastria, but poor 3 cycle per minute GMA, this predicts a poor response to therapy. In fact, when you see poor 3 cycle per minute activity, we know that there are insufficient ICCs in number and quantity, so you can have no electrical conduction. And these are the patients that will not respond to a stimulator insertion, nor will they respond to medical therapy because the conduction mechanism is interrupted. And instead, therapy in this particular group of patient might be using nitrous oxide to try and rebuild the microcirculation, as we see that is frequently deteriorated in the diabetic patient, resulting in poor 3 cycle per minute activity. This can then theoretically reverse the gastroparesis. So importantly, the EGG detects the 3 cycle per minute gastric motor activity compared to normals, and this allows us to personalize the medical therapy in patients with gastroparesis. When we try and evaluate the validity of using the 3 cycle per minute gastric motor activity, we developed a threshold that allows us to detect when the motor activity is excessive or where there is hypernormal 3 cycle per minute activity. So what we did is we designed a comparative trials using similar subpopulations of patients with gastroparesis. Some of those patients had the hypernormal EGG showing above normal 3 cycle per minute activity. These are the ones with functional outlet obstruction. And then as a control group, we took patients with gastroparesis who had normal 3 cycle per minute activity that fell within the population-based norms, and they served as the control group. We did pre- and 12-month post-pyloric dilation testing. This included a standardized 30-minute electrogastrogram water load test, a solid-phase nuclear gastric emptying study, as well as a standardized dyspepsia survey. In addition, endoscopic evaluation was carried out before and after pyloric dilation, which is done with a 20 millimeter through the scope balloon for a period of approximately 2 minutes. In this next slide, we're looking at the pre-dilation and post-dilation EGG and endoscopic pictures. If we look first on the left-hand side at the endoscopic picture, you will notice that this pylorus looks normal. Morphologically, it is normal appearing. There's no evidence of ulceration, there's no evidence of stricturing or scarring. This is prior to balloon dilation, and then on the right-hand side you can see, following a 20 millimeter balloon dilation, that the pyloric mechanism is still intact, but just slightly more open, and it will remain this way. When we look at the electrogastrogram, however, look here on this particular box showing the 3 cycle per minute activity level, and you will see that even prior to the water load, and then even worse following the water load, a significantly abnormal response to the water load. After dilation, you'll see that that 3 cycle per minute activity has now dropped back into the normal range in response to the water load as a result of the pyloric dilation. If we want to look at the dyspepsia score specifically, comparing the control group to the hypernormal GMA group, you will see here at every level, whether it be abdominal discomfort, bloating, discomfort worsened by eating, early satiety, fullness, or nausea, that in the normal GMA patient, there was no significant change pre- and post-dilation, indicating that there was no therapeutic advantage to treating those patients. However, in the hypernormal group, significant improvements in all categories were achieved, indicating therapeutic success, predictable therapeutic success, based upon the electrogastrogram finding. Looking at the results of the gastric emptying scan, we find similar findings. So looking at the mean percent emptying at 90 minutes, as well as at 120 minutes, in the normal control group, no significant improvements were noted in the pre- and post-gastric emptying. However, this is not the case in the hypernormal GMA group, where significant improvements occurred not only at 90, but also at 120 minutes. When we sit down and look now at the performance characteristics, and again, this is based upon a joint activity score where we determined that if you use this joint activity score and you have a threshold value of at least 0.59 that is calculated in a linear regression analysis, we find that the positive predictive ability of doing the electrogastrogram with regard to the success of dilation, the results show us a sensitivity of 96.15, which is very high, with a specificity that is equally high of 75. In calculating this, this means that the correct classification as to whether a successful dilation or an unsuccessful dilation will occur, the correct classification gives us a predictive value of success of 93.33%. Based upon these findings, we're able to state that electrogastrography, or EGG, is able to define the normal 3 cycle per minute GMA subtypes of gastroparesis, and that the hypernormal group, the hypernormal subtype group, we know responds to endoscopic pyloric balloon dilation. Other studies have demonstrated that it will respond to surgical treatment as well as Botox injection. We also know that the normal 3 cycle per minute control group with gastroparesis did not respond to endoscopic balloon dilation, therefore should not be treated in this manner. A derived linear regression analysis of the 3 cycle per minute GMA data predicts resolution, which is to say cure of gastroparesis in response to endoscopic balloon dilation. This in addition to predicted symptom response improvements to endoscopic therapy. Therefore, we feel that further application of this technology may allow additional predictions with regard to response to other therapies, such as Botox, pyloroplasty, the implantation of a gastric stimulator, or perhaps even obesity treatments.